Hi everyone, my name is Dr. Vimal Verma, clinical anesthetist and lecturer from UiTM Sungai Buloh campus. Today I'm going to present about blood pressure monitoring. The content of my presentation today will start off with an introduction to blood pressure monitoring and definition of blood pressure. Next, we will dwell into principles and physiology behind the blood pressure monitoring. We have to know about the concept of systolic blood pressure, diastolic blood pressure, pulse pressure, and mean arterial pressure. Next, we will move on into invasive versus non-invasive methods of blood pressure monitoring. And then we will dwell into more detail about invasive arterial blood pressure monitoring, including the setup, the components. Then we will discuss about the invasive arterial blood pressure waveform, and finally we talk about pros and cons of each method. Introduction. What is blood pressure monitoring? Blood pressure monitoring is a basic hemodynamic monitoring. It's a simple monitoring, but it can give us a very crucial info regarding a patient's health status. It is a routinely done monitoring. It gives us an overall view on patient's cardiovascular status. This is the blood pressure categories which was obtained from American Heart Association. A normal blood pressure said to be below systolic blood pressure of 120 and diastolic blood pressure of 80. A blood pressure which is more than 120 systolic and diastolic 80 will be considered elevated, and further increase in systolic and diastolic blood pressure will be categorized as stage 1, stage 2 and stage 3 or hypertensive crisis. The principles behind the blood pressure monitoring. What is blood pressure? Blood pressure is the force exerted by the blood upon the walls of the blood vessels or chambers of the heart. What does it mean? We have our blood that flows around our body, circulating in the blood vessels, and these blood particles will exert a certain amount of pressure on the walls of the vessels that they are flowing in. So this is the blood pressure. It is measured in units millimeter mercury, and it is affected by various factors which affects the blood circulation. The blood pressure measurement devices works on the principle that blood flow in a continuous column in our body, and the blood exerts a pressure on the wall of arteries during the various parts of the cardiac cycle, systole and diastole. The pressure that exerted by the blood on the wall of arteries are not the same throughout the cardiac cycle. Bear in mind, these pressures are measured using an exogenous energy to obliterate the blood flow. Let me clarify this again. So, when our blood is flowing in a blood vessel in a continuous column, they do exert a certain amount of force on the wall of the arteries. So how do we can exogenously measure using a device? By applying an exogenous force, mean by using a cuff pressure, or while we inserting an arterial cannula, which cause an obliteration to the continuous blood flow, and then later on this energy, kinetic energy, will be converted into mechanical uh, into electrical energy, so we can get the blood pressure measurement. As we can look into here, the arterial wall and the pressure exerted by the blood pressure during heart contraction and relaxation are not the same. Blood pressure as an overall reflects the blood circulation in the body. The blood circulation is affected by the volume of the blood, myocardial performance, and blood vessel tone. Mean arterial pressure. Mean arterial pressure is given by formula cardiac output times systemic vascular resistance. As in what we have mentioned before, blood pressure reflects the blood circulation and is affected by the volume of blood, myocardial performance, and blood vessel tone. So cardiac output is a surrogate marker of a myocardial performance, and systemic vascular resistance is a marker for blood vessel tone. And the volume of blood is a parameter within the cardiac output. because cardiac output equivalent to stroke volume. This is the volume that we talked about, and the heart rate also a component of myocardial performance. Thus, when we extrapolate this equation and substitute the cardiac output equation into the mean arterial pressure equation, we get a formula of mean arterial pressure equivalent to stroke volume times heart rate times systemic vascular resistance. So this is to tell that there are all these factors can affect our blood pressure. So as we look into this is a continuous column of the blood. From the heart, it goes to the periphery, it goes to the systemic circulation, and the venous return brings the blood back into the right heart. So the mean arterial pressure is cardiac output times systemic vascular resistance. So a blood pressure is indirectly tells us about the heart function and the full systemic circulation of the blood within the body. Mean arterial pressure equivalent to cardiac output times stroke systemic vascular resistance, and cardiac output is equivalent to stroke volume times heart rate, and mean arterial pressure equivalent to stroke volume times heart rate times systemic vascular resistance. I'm re-emphasizing this slide many times because all these factors may affect the patient's blood pressure. So we need to bear this in mind during our clinical practice. So when a patient is having hypotension, we need to consider all these parameters can be affected. Definition. What is systolic blood pressure? Systolic blood pressure reflects the arterial pressure resulting from the ejection of blood during ventricular contraction or systole, whereas diastolic blood pressure reflects the arterial pressure of blood during ventricular relaxation, diastole. Pulse pressure is systolic blood pressure minus diastolic blood pressure. This is the difference between the systolic pressure and the diastolic pressure. The mean arterial pressure would be diastolic blood pressure plus 1/3 pulse pressure or systolic blood pressure minus diastolic blood pressure. So the mean arterial pressure represents the average blood pressure in the arteries. That is the average force driving the blood into the vessels. So this is just a recap. Mean arterial pressure is equivalent to diastolic blood pressure plus 1/3 pulse pressure, and pulse pressure being systolic blood pressure minus diastolic blood pressure. So MAP is equivalent to diastolic blood pressure plus 1/3 systolic minus diastolic blood pressure. As we look into this picture, this is a diagrammatic depiction of that formula. So this will be your diastolic blood pressure, this will be your systolic blood pressure, and the mean arterial pressure will be the average, and the differences between systolic and diastolic would be your pulse pressure. As we can see over here, the blood pressure from the aorta, as it goes into a smaller vessels, the blood pressure drops. Next, we move on to the methods of blood pressure measurement. It can be divided into non-invasive and invasive method. Non-invasive blood pressure, NIBP, invasive arterial blood pressure, or we call it an intra-arterial blood pressure, it's called an IABP. So non-invasive blood pressure, it is broadly classified into auscultatory method, which is sphygmomanometry, or oscillometric method manual, and oscillometric method automated. Whereas invasive blood pressure measurement will be done by placing an arterial cannula within the blood vessel. Auscultatory method, also known as sphygmomanometry. It relies on listening to coracoid sound with a stethoscope while inflating and deflating a blood pressure cuff using a mercury manometer. How do we do it? The initial part is the cuff is placed on the arm and the cuff is inflated above the estimated systolic blood pressure, occluding the blood flow in the site. And the stethoscope will be placed beneath the cuff at the artery that is being occluded. Step 2, the cuff is slowly deflated while listening with the stethoscope over the brachial artery, and we will listen for coracoid sounds. So this is how it is done. So this is the cuff that is being placed, and the blood pressure will be inflated. Cuff will be inflated until the brachial artery or the site that the artery is present is occluded, since there is no flow and there is no more sound is heard. Next step, the cuff will be slowly deflated, and the first sound that is appear, and that pressure would be the systolic pressure, that is the coronal cough sounds. As the pressure of the cuff being deflated slowly, the sound become quieter, and at middle point there will be a highest oscillation from the blood vessels, blood flowing in the blood vessel exerted on the wall, that causing rise in volume, that will be the mean arterial pressure, and then the sound will muffle again, and at the end the sound will disappear as the pressure of the cuff being deflated. That would be the loss of sound, coronal cough sound 5, which is taken as the diastolic blood pressure. Please look into this picture as I move my cursor around. So first, this is the part the pressure is being inflated to a certain level until no more sound is heard and the vessel is completely occluded. As the cuff pressure is being slowly deflated or reduced, the first sound will appear, which corresponds to your systolic blood pressure. And the deflation of the cuff slowly continues until at one point there will be a maximum sound or maximum oscillation, which is corresponding to the mean arterial pressure, and further deflation of the cuff leads to disappearance of sound, which will correspond to diastolic blood pressure. And later on, the cuff will be continuously open. The arterial wall is continuously open because of no more pressure exerted and there is no more sound heard. If we look into the picture downward, it is just a representation in a different manner, showing our oscillation as per the cuff inflated and being deflated. As we can see here, initially there is no oscillation because of the cuff being completely occluding the artery, and as the cuff being slowly deflated, the oscillation increase. The first oscillation present, which corresponds to the first coronal sound, will be the systolic blood pressure, and as the oscillation increase at the midpoint, that would be your mean arterial pressure, and finally it disappears corresponding to the diastolic blood pressure. Okay, this is the coronal sound appearance from the first, and it become disappearing, and the middle part being the highest oscillation. And if we palpate the radial artery during this procedure, we will do it in a Riva-Rocaille palpation method. It goes to the same fiber, where we can initially we don't find a good pulse volume, and the pulse volume initially appears corresponding to the first coronal sound, and later on getting more louder corresponding to mean arterial pressure, and finally it will become normal corresponding to the diastolic blood pressure. Next, we move on to oscillometric manual method. It is detection of the blood pressure by measuring oscillations in the blood flow within the artery beneath the cuff. It is almost similar to the auscultatory method, in which it differs only by in the auscultatory method we are listening to the coronal cough sound, whereas we are sensing the oscillation in the blood vessels during the different inflation and deflation phase of the cuff. Oscillometric method uses oscillotonometer. This is an oscillotonometer which comprises of two overlapping cuffs, which are connected by two tubes to two aneroid bellows. Bellows connected to the lever system, which is the pointer. One cuff controls pressure and one more cuff senses. It is the same as the previous method, where the systolic blood pressure, the needle seems to make abrupt increase in amplitude, which corresponds to the first appearance of the coronal sounds. Next, mean arterial pressure would be the maximal oscillation, whereas the coronal sound speed be the loudest. And finally, sudden decrease in the amplitude oscillation corresponding to the disappearance of coronal sounds. The same concept is being applied in an automated manner, whereas the deflation and inflation of the cuff is controlled in an automated technology. And by sensing the oscillation and displaying it in a digital manner, we get the oscillometric automated method. It is a single cuff compared to the double cuff used in the manual method, which occludes the arterial flow, then deflated. The oscillations and the correspondence to systolic blood pressure, MAP, and diastolic blood pressure are the same. And this oscillation will be amplified, will be processed, and be displayed in the digital monitor in a numerical form. Oscillometric automated method are called as Dynamac, which is device for indirect, non-invasive automated MAP measurement. Next, we move on to invasive arterial blood pressure measurement. This is a simplified setup of an invasive arterial blood pressure measurement, where a cannula is being placed in the patient's artery, radial artery, connect to a transducer system, which is connected to a pressure bag, which is high pressure via a saline filled tubing, and the transducer also connected to a electrical monitor to display the waveform and the numerical blood pressure. IABP setup comprises of 5 important components. The first component would be the intra-arterial cannula. Second would be the fluid-filled tubing. Third is the transducer. Fourth would be the infusion or flushing system, which is high pressurized. And finally is the signal processor, amplifier, and display monitor. Each of these systems has their own criteria to be met, so the blood pressure measurement is accurate and reliable. First, we will talk about intra-arterial cannula. An ideal intra-arterial cannula for an accurate blood pressure measurement should be wide and short. This is to reliably transmit the energy from the blood flow to the display monitor. Okay, forward flowing of the blood contains kinetic energy. When the forward flowing blood is suddenly stopped by the tip of the catheter within the vessel, this kinetic energy is partially converted into pressure and then displayed in a numerical form in the display monitor after being processed within the transducer. The common cannulation sites for arterial cannula would be radial, ulnar, dorsalis pedis, posterior tibial, and femoral arteries. Fluid-filled tubing. Fluid-filled tubing provides a column of non-compressible, bubble-free fluid between the arterial blood and the pressure transducer for hydraulic coupling. This fluid-filled tubing, as is mentioned here, it should be non-compressible. It shouldn't be a very soft, easily kinked material, and it should be bubble-free within the column. Ideally, the tubing should be short, wide, and non-compliant to reduce damping. What is damping? We will dwell into it in a short while. It is very important to reduce any extra three-way taps and unnecessary length of tubing to also reduce the damping. Next, we move on to transducer. This is the very important component of the IABP setup, in which it converts the mechanical impulse of the pressure wave from the intra-arterial cannula into an electrical signal through movement of a displaceable sensing diaphragm, which functions on a principle of strain gauge and Wheatstone bridge circuit. So this is the transducer. Within the transducer, it is functions on the principle of strain gauge and the Wheatstone bridge circuit. So if you look into this picture, this would be your transducer. This end is lines to patient attaches here, whereas this is the cable that is going to the monitor, and this would be the end that connected to the pressurized bags. And within this component, there would be the strain gauge, a replaceable sensing diaphragm, and the Wheatstone bridge circuit, which converts the mechanical impulse into an electrical impulse. What is strain gauge? It works based on the principle that electrical resistance of wire or silicon increases with increasing stretch. The flexible diagram is attached to wire or silicon strain gauges in such a way that with movement of the diaphragm, the gauges are stretched or compressed, altering this resistance. And this will undergo the Wheatstone bridge circuit, which is designed to measure the unknown electrical resistance. This is the physics behind the transducer, which helps us to get the blood pressure monitoring. Next, we move on to the techniques that involve in the calibration of the IABP setup. It involves zeroing and leveling. First, we talk about zeroing. What is zeroing of transducer? Zeroing of a transducer is important to prevent any inaccuracy. For a pressure transducer to read accurately, atmospheric pressure must be discounted from the pressure measurement. It is done by exposing the transducer to atmospheric pressure and calibrating pressure reading to zero. This is done by opening the stop valve clock and exposing it to the atmospheric environment and pressing the zero button on the monitor, which will level up. It will zero the transducer and discounting the atmospheric measurement. The display monitor will show 0 and 0 process completed. At this point, the level of the transducer is not important. The leveling comes after this. A transducer should be zeroed several times per day to eliminate any baseline shift, and it is also should be done anytime when there is a disconnection from the setup. Next, we move on to leveling of transducer. Leveling of transducer usually taken to be level with the patient's heart at the fourth intercostal space in a mid-axillary rhyme. So this is the fourth intercostal space at the mid-axillary rhyme, which is called as phlebostasis axis. At what does it mean, phlebostasis? At this level, there is no blood flow. It is a blood flow are at static. It is called phlebostasis. Improper level of your IABP transducer makes an error due to hydrostatic pressure being measured in addition to blood pressure. Any decrease in the transducer level from the patient's phlebostasis axis cause a difference in hydrostatic pressure, and it can be added on into the blood pressure measured and cause an inaccuracy. Bear in mind that every 10 centimeter error in leveling from the phlebostasis axis, 7.4 millimeter mercury error in BP is measured. What does this mean? If a transducer is 10 centimeter low from the phlebostasis axis, the blood pressure reading is overestimated. And if the transducer is 10 centimeter higher than the phlebostasis axis, the blood pressure measurement is overestimated 7.5 millimeter mercury, and this go on. Let's say if the transducer is 20 cm above the phlebostasis axis, the leveling is inaccurate. 7.4 times 2, around 14.8 millimeter mercury under reading of blood pressure will be thing. So when the transducer is low, it overreads. When the transducer is higher than the phlebostasis, it underreads. Next, we move on to infusion or flushing system. So here a pressure bag, a normal saline solution will be put on in a pressure bag and it will be pressurized up to 300 millimeter mercury. It fills the pressure tubing, the saline filled tubing with fluid and helps prevent from clotting in catheter. It continuously flushing fluid through the system at a rate of 1 to 3 ml per hour by keeping a flusher bag at the 300 millimeter mercury. Apprenizing the flush system, it is not necessary. If you can look at it, this is the normal saline solution in a pressure bag which is being pressurized using a pressure bag 300 millimeter mercury, and the other end is connected to the flushing system at the transducer. Next would be the final part where signal processor, amplifier and display comes into function. The pressure transducer relates its electrical signal via a cable to microprocessor where it is filtered, amplified, analyzed and displayed on a screen as a waveform of pressure versus time. As a transducer contains strain gauge and Wheatstone bridge circuit, here the mechanical signal has been converted to electrical signal, and this electrical signal is being sent to this digital display after being microprocessed, filtered, amplified and analyzed. In this time, there is an analysis going on called as Fourier analysis, which I'm not talking in detail here, in which it actually filters multiple waveform and showing us the one waveform that we see in the monitor. It gives us a beat-to-beat blood pressure that can be seen. Further analysis of the pressure waveform actually can give us more information about the cardiovascular status as like cardiac output and other cardiovascular parameter when they are incorporated in the advanced hemodynamic monitoring such as cardiac output monitoring. This concept of using arterial blood pressure waveform in cardiac output monitoring is called pulse contour analysis. Next, we talked about how intra-arterial blood pressure waveform can give us more information apart from the blood pressure alone. So we have to talk about the IABP waveform. This is the normal IABP waveform. It comprises of a systolic upstroke, a dicrotic notch, and a diastolic runoff. A peak of the systolic upstroke is called the systolic blood pressure, and the lowest point where during the diastolic runoff will be your diastolic blood pressure. The difference between systolic and diastolic would be your pulse pressure. There is a dicrotic notch which corresponds to the aortic valve being pushed into the ventricular during the ventricular ejection. Next, we also can see the area under the curve, which is under this part, which is corresponds to our mean arterial pressure. So a blood pressure IABP waveform is divided into anacrotic limb and a dicrotic limb. If we look into this one part of the arterial blood pressure waveform, we can see that the systolic area, the arterial blood pressure waveform is divided into systolic area and diastolic area. The systolic area is related to preload and contractility, and diastolic area is account for your afterload, and compliance is inversely proportional to the mean arterial pressure. As we already mentioned about, cardiac output is equivalent to stroke volume times heart rate, and the stroke volume is the area under the curve under systolic component. So the area under the curve systolic area times the heart rate will give us the cardiac output, whereas the area under curve of systolic area times diastolic area corresponds to mean arterial pressure. Next, we move on to damping. Damping is anything that reduces energy in oscillating system that will reduce the amplitude of the oscillation. It means what is being suppressed. Damping is something that's suppressing the oscillation in the system, equivalent to something that making the energy being dissipated from the system. Some degree of damping or suppression of energy is required in all systems, which is called as the critical damping. Damping affects systolic blood pressure and diastolic blood pressure, whereas mean arterial pressure is unaffected. When there is insufficient damping, it is called underdamping, and underdamping causes overreading of systolic blood pressure and underreading of diastolic blood pressure. Whereas when there is excessive damping, called as overdamping, it is overreads diastolic blood pressure and underreads systolic blood pressure. Next, we're going to look into arterial blood pressure waveform with various damping. What are the causes of damping? The damping can be caused by many factors. Overdamping are usually due to long and soft tubing. We have talked about the ideal fluid-filled tubing should be a short and non-stiff, a short and stiff tubing. Any air bubbles in the tubing also can cause overdamping. Kinks and clots as well contribute to overdamping. As for underdamping, a short and very stiff tubing can also become an issue and causes underdamping. A low pressure bag system causes less suppression of energy, so thus leading to underdamping. Other than that, artifact from the catheter and tachydysrhythmia also causes underdamping. This is a diagram that shows various waveform morphology in a patient who have damping. The middle one shows us the normal non-distorted waveform which has an anacrotic and a dicrotic limb in a systolic upstroke and a diastolic runoff with a dicrotic notch is being seen well. Whereas in an underdamped system means a system which has less suppression of the energy. As we have talked about, the diastolic blood pressure is being underestimated and systolic blood pressure is being overestimated. As for in an overdamped system, the diastolic blood pressure being overestimated and systolic blood pressure being underestimated. There is a way for us to know a system is underdamped or overdamped is by performing a square wave test or Farsh plus test. What happens when we perform a square wave test? If the system is optimally damped in a normal waveform, there will be a square waveform because of the high pressure. The next will be the waveform will present with one or two oscillations only. If the pressure is underdamped, it means there is less suppression of energy after the square wave test. There will be a multiple oscillation before a waveform can be displayed. Whereas in an overdamped system, in a system being overly suppressed, after the square wave test, there won't be any oscillation and there will be a following of the display of the waveform. Next, we move on to pros and cons of each method. Next, we talk about pros and cons of each method. First, we will dwell into invasive blood pressure monitoring. Invasive blood pressure monitoring is known for its accuracy and reliable. It can give us a comprehensive data, not only the numerical blood pressure alone, it also can give us input regarding the patient's myocardial performance, the contractility, stroke volume, and so on. It gives us a real-time beat-to-beat monitoring, which is very helpful in a critical care settings. Invasive blood pressure monitoring has its many complications compared to non-invasive. The first being injury to the arterial wall causing bleeding, hematoma, and infection, and it also causes arterial vessel stenosis and can cause to a patient ischemia of the distal extremities. Patient discomfort and pain is another factor that must be looked into when they plan for invasive blood pressure monitoring. Thus, adequate LA or sedation had to be given to make sure patient is not restless. It is very resource intensive compared to non-invasive blood pressure monitoring because the consumables are much more and maintenance of an arterial cannula need expertise and to prevent further complication. And even though invasive blood pressure monitoring is known for their accuracy, but if the system is damped, there can be an error in blood pressure monitoring. For the non-invasive blood pressure monitoring, they are famous and more widely used because of their safety and mobility and ease of use. It can be practically used in any setting by any person. Okay, the correct placement, uh, choice and placement of the cuff is more than enough, especially in an automated non-invasive blood pressure monitoring. Patient comfort is much more and compared to your invasive blood pressure monitoring. However, in non-invasive blood pressure monitoring, performance are very questionable in a critical situation, in a patient who are in shock, patient who are in ICU setting or under anesthesia. And because of their choice of cuff is very important, and that can lead to cuff size errors, the accuracy is questionable. And next, limited data is obtained from the non-invasive blood pressure monitoring. So, for conclusion and summary, blood pressure monitoring is a basic and routine monitoring for all grounds of patient. It provides simple but valuable information on cardiovascular status, guiding treatment decision and improving patient outcome. Non-invasive techniques are safe and easy to use, while invasive methods offer continuous real-time data. The choice of method depends on individual patient needs, clinical setting, and resources available. That's all from me. Thank you.